So I'm going to take just a few minutes to talk about diagnostics and how important they are from the public health perspective, and what a critical component they are to our success in protecting Americans from infectious diseases. You know, I guess these days, people don't need to be reminded of how often emerging and reemerging infectious diseases appear around the globe, and how these infections can surprise us if we just even think over the last year or so of Ebola and then Zika. These are two infections that we were aware of, but they behaved in a way that was quite unexpected and resulted in unexpected results. And so this is just a map which details some of the emerging and reemerging infectious diseases over the last, I guess, maybe 10 years or so. Now, I wanted to give a few examples of how immediate infectious disease threats, current threats, what they are and what the role of diagnostics has been. So first, of course, I don't think I need to remind people about the 2014 to 2015 Ebola outbreak, which was the largest in history, with over 11,000 deaths reported in the 3 countries in West Africa. And from the CDC perspective, it was our largest outbreak response in our history. It highlighted the need for international coordination and exposed the weaknesses in the public health infrastructure and the need for public health capacity building. And we found that it required both traditional epidemiology and innovative solutions, especially actually in the area of diagnostics. Another, of course, current threat is the Zika virus being detected in the Americas. As many of you know, this virus is closely related to dengue, West Nile, and yellow fever viruses. It's transmitted by the Aedes aegypti mosquito, which is the same mosquito that transmits dengue and chikungunya. It's been recently identified as a likely cause of microcephaly, which is a devastating birth defect, and I think all of us that have seen these terrible pictures from Brazil are quite alarmed and saddened. It's been declared a public health emergency of international concern by the World Health Organization, and more than 30 countries and territories in the Americas have reported local transmission. Much is still unknown, but research is ongoing in earnest. Few other emerging infectious disease threats that are very much in the front of our minds. Antibiotic resistance. As you know, about 2 million people are infected each year with bacteria that are resistant to antibiotics, with 23,000 deaths and an additional 14,000 deaths a year from Clostridium difficile, which is a healthcare-associated infection that is driven by antibiotic use. $20 billion a year in healthcare costs, and I think as we've said, and many other partners have said, Carol certainly has said loud and clear, that we need to act now, or even drugs of last resort will soon be ineffective. Food safety is another area of concern, where 48 million Americans get sick from foodborne disease each year. 128,000 are hospitalized, and there are 3,000 deaths. We find that an increasing proportion of these outbreaks are multi-state. These multi-state outbreaks tend to be the most deadly. We estimate that more than half of deaths in reported foodborne outbreaks are in multi-state outbreaks. We also see old diseases manifesting themselves in new geographic areas. So cholera is a very current example. Outbreaks happened for years in Africa and other parts of the world, but in 2010, we confirmed cholera in Haiti for the first time in more than a century, resulting in, again, tragically, over 8,000 deaths. You may have seen in the news last year, or perhaps in our publication, an increase of cases in plague in the United States in 2015, where we usually certainly see a very small handful of plague cases every year. But in 2015, we saw a total of 16 cases in 6 states with 4 deaths. And again, just on Zika, to remember that Zika virus was actually first isolated in Uganda in 1947, but it only was detected in the Americas in the middle of last year in Brazil. So why are diagnostics important for infectious diseases? What am I doing here, in other words? There's actually a number of important points to be made here. First of all, as I've said, diagnostics is an important part of the public health system. We need to be able to correctly diagnose and quickly diagnose patients in order to conduct surveillance for emerging and evolving pathogens. In other words, we have to be able to track what's happening reliably. If we don't know what people have, we obviously can't track effectively. Diagnostics are pivotal to stopping outbreaks, and they inform much of our infection control and prevention efforts. The microbes are changing all the time. That's what microbes do. And so we need new tools and methods to stay one step ahead of these microbes as they continue to change and evolve and surprise us. I wanted to now give some examples of some technologies that we've been either developing or help develop with partners. And these are often, as you can see from this list here, these are infectious diseases that have important public health implications. First, with yellow fever, we've actually developed a new ready-to-use laboratory test kit that produces results in 4 hours as opposed to 2 days. And we've actually been using some of these kits in a current yellow fever outbreak in Africa. With dengue, we developed a more accurate diagnostic test using sort of molecular methods that can detect all the current strains in most patients. And rabies, which is an important public health problem globally and results in hundreds of deaths each year, primarily in young children. We've developed new, safer, and more effective vaccines for people and animals. With Ebola, there were actually, diagnostics were an extremely important part of the Ebola response, as I mentioned, and I just picked out one example here to mention because it is an example of a good partnership between industry and CDC. We provided technical assistance to this company, actually, but actually 4 or 5 companies for an oral fluid assay for Ebola that can easily be used in the field. And this particular OraSure test was one that was eventually deployed and used widely in the field and was quite helpful in terms of rapidly distinguishing who might be infected from who was not infected. For plague, we have developed a rapid, inexpensive point-of-care bedside diagnostic. It's a Dipstick Assay. And this assay we've been using especially in Uganda where plague is endemic and have been able to distribute this assay to some of the local health districts and have a number of really good stories of people who live in remote areas were brought by motorbike to a local health clinic where they had the dipstick, diagnosed plague, and were able to get treatment to the person very quickly and probably save his life and certainly prevent transmission. In invasive candidiasis, there's a patent-pending diagnostic assay to detect echinocandin resistance in invasive candidiasis, which is the most common cause of healthcare-associated bloodstream infections in the United States. So now I'm just going to spend a couple of minutes looking forward a little bit and talking about some of the critical areas for diagnostics development that we're working on currently. First, I wanted to just spend a minute or two on antibiotic resistance, and this is just to remind everybody about the national strategy for combating antibiotic-resistant bacteria, which we released last year. And the third of the 5 components is advancing development and use of rapid and innovative diagnostic tests. And so that just gives a sense of how important we think better diagnostics are in our fight against antibiotic resistance. From a public health perspective, in terms of antibiotic resistance, we need diagnostics to detect new resistance or resistance trends for prevention. Our current methods for detecting resistance are quite labor-intensive and cumbersome and not very quick. Diagnostics can certainly prevent transmission. For example, if we had an easy way of detecting CRE colonization, this would certainly help with more rapidly implementing our prevention strategies. And of course, diagnostics can fundamentally improve antibiotic use, which we know is a major driver of antibiotic resistance, in terms of helping to help clinicians know when to use an antibiotic. So is it a viral infection or is it a bacterial infection, and which antibiotic to use? In other words, what is the pathogen sensitive to? Whoops, I just got ahead of myself. So diagnostics to improve antibiotic use, as I said, to differentiate viral versus bacterial infections, to differentiate infection from colonization, and to rapidly detect antimicrobial susceptibility. Advanced molecular detection, or bioinformatics and next-generation sequencing, is really going to be pivotal for bridging the gap between data for patient care and data for a public health response. You know, sometimes, oftentimes, and we hope most times, the diagnostics needs for patient care line up very well with public health needs. But that doesn't always happen, as I'll mention in a moment about food safety. But in this case, I think that they do line up relatively well in terms of outbreak response and identifying patients who are colonized. There is this issue here, the first sub-bullet here, about new resistance and new trends in an era of culture-independent diagnostic testing. And this is something that, as I mentioned, we're quite concerned about in the area of foodborne pathogens. There's also a potential place that the clinical needs and the public health needs might not line up perfectly, and we need to figure out how to bridge that gap, at least in the short term, so that what a clinician needs to know is what is this infection and what can I use to treat it? Whereas for the public health, from a public health perspective, we really need to understand what is the mechanism of resistance, how does this one particular isolate compare to another from the perspective of the whole sequence? How same is it and how different is it, so that we can track trends in spread of different kinds of pathogens, and we need a culture. At this point, we need a culture to answer those questions. So we're at a stage here where we're a little bit off sync in terms of the clinical needs and the public health needs, and this is just an area where we need to just stay well coordinated and figure out how to bridge that gap. There are many opportunities for collaboration, and we're kind of doing our part to help spur innovation. So, for example, last year we developed an antimicrobial resistance isolate bank, and this is we were able to do this because at the CDC we have a very, very large collection of well-curated isolates. That is, we know a lot about where the particular bug came from. So we've developed a number of different panels of different organisms that diagnostics developers can use in their diagnostic assay development. And this has been actually quite popular, and we've had lots of orders, which we're very happy about, and we hope to be able to expand that. We certainly like to assess and promote the economic and other benefits of diagnostics. In other words, just to provide some some context for why they're important, and expand our educational efforts to doctors and laboratorians. We play a role in implementing current and future tests with treatment guidelines and identifying best practices for diagnostics, making sure that our public health laboratory capacity is leveraged and is well integrated with the clinical laboratory capacity. And again, to this issue about culture-independent diagnostics and our concern about how this trend, which is clearly beneficial in the clinical realm, might cause some difficulties from a public health perspective. I'll just make a couple more points about diagnostics development. First of all, new technologies, sequence-based diagnostics, are going to be really important, obviously, in this and the next generations of diagnostics. And again, this culture-independent diagnostics issue, where we kind of need to get ourselves synced up and are working hard to bridge the gap and hope that actually the diagnostics companies can help us with that by being aware of what our needs are and thinking about how some of this shortfall can be mitigated when they manufacture their kits. I'm going to say 2 words about Zika virus diagnostics, and I'm going to stop because I see I've actually been talking for longer than I thought I was going to be. So Zika virus diagnostics is obviously something that's in the top of everyone's mind. For right now, there are no tests that are commercially available, but we certainly hope that some of the diagnostics companies will get interested in manufacturing tests. So we have been working as a priority to develop faster and more definitive tests and expand the capacity of our state public health laboratories for Zika testing in the interim, because we obviously need Zika testing for a number of different reasons. So we have a couple of assays. One assay, our IgM MAC ELISA, was just received an emergency use authorization by FDA, I think, last week. And so we are working to get that test out to state public health labs. We ourselves are performing testing on request. We, I think, are now testing something like 1,000 specimens in our laboratory every week. And we're working very hard to expand diagnostic capacity. The two tests, the current tests, there is an RT-PCR test, but it can only be used when, well, it's only really valid when Zika virus is still in the blood, which is a relatively short period of time, only a week after symptom onset. And so this test is great if you see the patient at the right time, but otherwise it's not all that helpful. We have an IgM, this is the IgM MAC ELISA I just mentioned, which does detect a past infection, becomes positive about 4 days after symptom onset, but there's some significant cross-reactivity with other flaviviruses like dengue virus, yellow fever vaccination, and so that can produce both false positive and inconclusive results. And then there's this neutralization test that can be used to help sort out an IgM MAC ELISA, which is inconclusive or hard to interpret. So I guess that's it for me, and I thank you very much and look forward to our further discussions.